I'm Dr. Victoria, and this is George.
Today, we are going to talk about depression. For the past several months or so, George has not been feeling well at all. He has been feeling very sad. He does not want to participate in any of his regular hobbies. He is feeling guilty that he did not spend enough time with his uncle who died before he passed away. He has low energy, feels like he can't concentrate, and he does not want to eat very much. He's becoming a bag of bones. What is happening to George is that he is having a major depressive disorder. First, who is at risk of depression? Let's look at the epidemiology. The lifetime risk of developing depression is 20 to 25% in females and 7 to 12% of males. There's not a social or economic correlation. Singleness is a contributing factor. And if you live rurally, have been through a divorce, lost a parent when you were less than 11 years old, or experienced the death of a spouse, you are at increased risk. To make the diagnosis of depression, someone should have at least one major depressive episode. This would last at least 2 weeks with 5 or more of the following symptoms: depressed mood, loss of interest or pleasure in most or all activities, increased or decreased sleep, a change in appetite or weight, whether increased or decreased, psychomotor retardation or agitation, low energy, poor concentration, thoughts of worthlessness or guilt, and recurrent thoughts about death or suicide. Persistent depressive disorder or dysthymia is persistent depressed mood for 2 years with at least 2 of these symptoms, but in children or adolescents, it's only 1 year. An increase or decrease in appetite, increased or decreased sleep, low energy or fatigue, poor self-esteem, poor concentration or making decisions, and feeling hopeless. The biggest break with any relief of symptoms should not be more than 2 months. Some common screening tools we use to get the conversation started about depression includes the PHQ-9 for depression and the GAD-7. This stands for Patient Health Questionnaire and General Anxiety Disorder. Given together, this is a quick way to know if I need to start a conversation with a patient who might be struggling but shy to bring up the topic. I'll find a version to link down below so you can check it out too. When screening for depression, it is important to ask about manic or hypomanic episodes. These will be periods of feeling like one is on top of the world. There may be decreased need for sleep. Someone's thoughts may be racing. They may be bouncing from one activity to the next. They may engage in risky behavior in relationships or their finances. This is important because if we were to start treatment with a medication for depression, we would not want our patients to rebound into a manic state. For treatment, it is best to have a combination of pharmacotherapy and psychotherapy. The combination of these two is more effective than just one treatment alone. Sometimes people chalk this up to something you just have to snap out of, or that you have to just get over it. But we know from brain imaging that people with depression have areas of the brain that are just not as activated as in a healthy brain and are not working well, while other areas of the brain may be working too hard. SPECT images, or single photon emission computed tomography, have been able to give us some really interesting insights into what is going on in our brains. It can be helpful to share this with our patients, especially if there's some stigma in their culture or family about using medication for behavioral health conditions. Whether someone wants to use medication or therapy or both to help treat their depression, it is an individualized decision, and we want to be supportive in whatever our patient's choice is. For our medications, first line, we want to start with a serotonin reuptake inhibitor, such as escitalopram, aka Lexapro, fluoxetine, aka Prozac, or sertraline, aka Zoloft. These SSRIs are also helpful in the treatment of anxiety. If there is any overlap of depression and anxiety, this is a wise choice. It is important to counsel patients that these medications take 6 to 8 weeks to even start working, and to give the medication a fair trial before saying they're not noticing any change. We always want to titrate up slowly, and when coming off these medications, titrate down slowly as well. Some common side effects include insomnia, headache, GI upset, and sexual dysfunction. When there are comorbidities such as fibromyalgia or chronic pain, duloxetine is a serotonin norepinephrine reuptake inhibitor that can help alleviate some of those pain symptoms as well. Common side effects of SNRIs include insomnia, tremors, headache, GI upset, and sexual dysfunction. Normally, we like to try 2 SSRIs, and if the patient is not having an appropriate response or the side effects are too significant, we will likely move to bupropion. Bupropion, also known as Wellbutrin, is a norepinephrine and dopamine reuptake inhibitor. Some common side effects include dry mouth, constipation, headache, nausea, sweating, weight loss, hypertension, myalgias, and rash. It is important to avoid bupropion if someone has a history of seizures, as it decreases the seizure threshold. Or, on the other hand, if someone is trying to quit smoking, bupropion has great efficacy in helping in that department. And if someone has depression in addition to a nicotine addiction, this might be a good choice for them. We have many different options for medications besides the ones I mentioned. Usually, we can find something that works well with these SSRIs, SNRIs, or bupropion. But there are many other options to highlight, such as the monoamine oxidase inhibitors and tricyclic antidepressants. We really don't run out of options when it comes to treating depression. For non-pharmacotherapy options, there are many: cognitive behavioral therapy, interpersonal psychotherapy, behavioral activation, family and couples therapy, problem-solving therapy, psychodynamic psychotherapy, supportive psychotherapy. There is many, and there's no evidence that one particular kind of therapy is better than the rest. But some goals in therapy may include a way to change thoughts, beliefs, attitudes, and behaviors that may lead to emotional distress. There can be social problem solving or family group therapy. We can target thoughts, whether there is a distorted thought about specific events, or perhaps there is all or nothing thinking and people go to the extreme in their view of the world. This is a way to explore ideas about the world, the future, and oneself that may not be true, but merely a perception and leads to distress. We can also target behaviors. This includes good sleep hygiene, physical exercise, including activities that bring joy to an individual or a sense of mastery, and improving social skills and social involvement. The presence of depression can be a little different depending on the age group as well. In the elderly population, they may have extra irritability rather than saying that they are sad. Sometimes they can be at risk of psychosis. There may be nihilistic negativism, ruminating thinking, or the thought that they're worthless, and this can take on the form of a thought disorder such as racing thoughts or fixed false beliefs. This might even be a good time to call your favorite psychiatry friend, because you might need some low-dose antipsychotics on board to help. This population may be asking themselves if they've been a productive member of society, if their life had meaning, and is there conflict or reassurance upon these reflections. Global independence can also have an effect. When starting any medication for mood in our elderly population, we always want to start at a lower dose and titrate more slowly. There should be some caution in using the SSRI Celexa in the older population with cardiovascular comorbidities. We should have great caution in using more than 20 milligrams, as there is QT prolongation. In our adolescent population, depression can look a little different. Individuals may be withdrawn, they may isolate themselves, and be less engaged in their regular activities. This is often reflected in schoolwork performance. There can be increased irritability, they can have decreased frustration tolerance, and be confrontational. They may want to drop out of a sport activity, saying they lost interest, or don't care, or are exhausted. For George, we'll get him plugged into some therapy, and he's keen to start a medication as well. We'll start him on some Lexapro with a slow taper, and we'll reassess in about 6 weeks or so to see if he's feeling any better. Thank you for joining me today, my healthcare team. I see patients every week who are struggling with depression, and it is so encouraging to see them get their zeal back for life. I hope you'll join us next time to see what George gets up to next. Bye-bye!